Hi, how are you? My name is Stephen Goldberg, and I'm really excited to talk to you today about surgery in the office. So I really appreciate your taking the time to review this information, and I hope it is very useful for you to learn about some of the exciting things that we're doing here at Titletown Sports Medicine and Orthopedics. So the title of this episode is Surgery in the Office. So the objectives will be to discuss how the cost of care is going to be intertwined with the quality of care. I'd also like to define a term called volant that has been associated with hand surgery in the office over the past number of years, as well as minor procedure field sterility, and why these two concepts are critically important to achieving cost savings, performing hand surgery in a safe and highly effective manner, and why patients, employers, insurers, as well as Bellin Health all can benefit from this type of medical service. Also, I'd like to demonstrate some of our own personal outcomes and the benefits that the Titletown Outpatient Office Procedure Room has provided since March of 2020. So the first thing I'd like to do is highlight a study where a cost analysis was performed looking at how surgical approach, as well as type of anesthesia, can impact the healthcare cost. And so this study analyzed the United Health Group database and looked at two different factors. There is a third major factor, the site of service, that also impacts cost of care, but this was not examined in this particular study. The study focused on surgical technique, doing a procedure open versus endoscopic for carpal tunnel, and either local anesthetic or some other type of anesthesia that required a different level of care, such as general anesthesia, regional anesthesia, or sedation services. And out of over 86,000 patients who underwent carpal tunnel release over this 4-year period, they were able to obtain some interesting information. And so the outcome of the study was they found that doing open surgical technique rather than endoscopic and using local anesthesia only, that was performed in only 16% of the cases during those years. But it was the least expensive type of care. It was on average $794 of cost savings doing open surgery rather than endoscopic. When you look solely at the type of anesthesia provided, local anesthesia alone was $654 less than general or regional anesthesia. And so the widespread adoption of local anesthetic for any surgical technique, open or endoscopic, would save $2.3 billion over 10 years. Now, if the surgeons and patients both select local anesthesia with the open technique, it would actually save $3.6 billion in healthcare costs over a decade. So let's look at the other cost of care factor that I mentioned, site of service. So ideally, where should a procedure like this be performed in many cases? So the cost implications in varying surgical technique, a setting, and the type of anesthesia, all three of those factors was analyzed in this study. And they looked also at multiple different payer mix during the study so that the results would extrapolate to a normal office practice. And so what was seen in this study was that the highest sample size of 135 patients underwent an open carpal tunnel release with the volant or local anesthetic technique. And so there has been a shift towards increasing this low-cost but high quality surgical technique. And this wide awake local anesthesia with no tourniquet, or Wallant technique, was set as our baseline measurement for total direct cost, as you see here in green. And if you look towards the right, the cost of care increases as you change either site of service, type of anesthesia, or endoscopic technique, such that the open operating room location with general anesthesia is 30 times the cost of care of doing that in the office. The other thing I wanted to mention on this slide is that the total combined payments only varied by 2.4 times. And so when the payments are disproportionately impacted compared to cost, that there can be a divergence in these measurements where we need to look both at payment from a reimbursement side as a healthcare system, but we also want to understand cost of care for delivering that same procedure and how to minimize that cost and help patients and insurers not overpay for care. So there are changing models in payments in healthcare that you may all be familiar with, where there has been an overall shift in many instances away from fee-for-service towards some other type of reimbursement. A term value-based healthcare can be defined as the quality of service achieved per cost incurred to provide that service. And so value-based healthcare would favor high quality and low cost services. So if we can do a carpal tunnel release procedure at a low cost in the office under local anesthetic with maintenance of our high quality, then that is a value-based healthcare choice that a patient can make. There are also other alternative payment models, bundle payments, etc. And so looking at all of these factors will help deliver healthcare with high quality and use cost-conscious choices. So how do we accomplish this? I've mentioned it a few times. Wallant, that stands for, again, wide awake, local anesthesia, no tourniquet. And why is it important to highlight the absence of a tourniquet? Well, there was a Canadian surgeon, or I should say is a Canadian surgeon, Dr. Don Lalonde, who has systematically studied how to safely perform office hand surgery. And that came out of some of the market dynamics with the Canadian healthcare system. And what he found is that the principles of needing to perform surgery in a bloodless or minimal bloody field is important so that the surgeon can adequately visualize small structures and avoid injury. So in the operating room, we usually use a tourniquet to achieve the bloodless field. But the tourniquet is like a blood pressure cuff that goes up and squeezes the extremity, and that can cause some pain. And so in order to tolerate the tourniquet and not remember any discomfort, patients often need sedation, regional, or general anesthesia for longer duration procedures. Now, if we don't want to use a tourniquet in an awake patient in the office, what else can we do? Well, what Dr. Lalonde studied was revolutionary for switching a paradigm from never giving any epinephrine near the hand or fingers to determining that it's actually very safe to inject certain doses and volumes of lidocaine with epinephrine and not have any high risk for adverse consequences and be able to safely have good visualization during surgery without a tourniquet. Now, there is a safety factor that's important to recognize where the epinephrine effects, if they were pretty significant, where the skin was very pale or the patient was having pain, that can be reversed with an injection of a different medicine called phentolamine. We have that stored on site, and thankfully, we've never had to use that medication, but it's important to be aware that it may be necessary at some point in time. We educate our patients very carefully about the techniques and medicines we use and what to look for if they have any concerns. Now, the office location, in order to be successful, really needs to have several things in order to achieve that success. Number one, we need to have sterile instruments and ability to recreate a surgical operating room environment in the office. We want to have safety in terms of patient health and monitoring and care. We want to ensure that the quality of care is the same in our office as it would be in any other location. We want to make sure that we are successful at being reimbursed with this new offering at Bellin. And we want to make sure there's actually patient interest in pursuing this treatment. So let's look a little bit more about the concepts of minor field sterility. So what that is referencing is doing some types of surgical procedures in what would be considered a minor procedure room. We want to use a single drape, have a single pair of gloves and a mask to try to provide a clean environment for the patient. The original description of this was to not wear a sterile surgical gown, to not have a hair covering. And we at Bellin wear both a sterile gown and a hair covering. We do not need to give prophylactic IV antibiotics for short duration soft tissue hand procedures. There is no need to wash every surface in the room between cases. And in these studies that showed safety, that there was no need to have any special airflow control, although we have collaborated with our hospital surgical service leadership and infection control to ensure we have appropriate air exchange in our Titletown facility. We use one nurse as a circulator and one assistant that is sterilely scrubbed, helping with the procedure. We do a pre-shower wash like the patients do for hospital-based surgery, both the night before and the morning of the procedure. Then upon arrival for the day of the procedure, patients will thoroughly wash their hands and arms. We then do surgical skin prep and sterile draping. The results from this literature review of other surgeons who have looked at their results show that there were over 1,500 carpal tunnel release surgeries performed by 6 surgeons in 5 centers. They did not exclude any patients due to use of steroids or diabetes. They had a very low 0.4% superficial infection rate. Most of these resolved with just oral antibiotics and no deep infections, no hospital admissions, no repeat surgeries or IV antibiotics. So a very safe technique. The office location benefits also can save on waste production. So what's very interesting is that in 2007, US healthcare facilities contributed to 10% of total greenhouse emissions and 9% of all US air pollutants. And that healthcare is the second only industry to the food industry in its contribution to landfills. Much of our red bag or infectious pathologic waste is often misallocated, where things that are placed into those special bags don't really need to be in there. So we have an opportunity to reduce waste as well. So another study was performed looking at over 1,000 hand surgeries. And by using these minor field sterility techniques with limited disposable supplies, can save $10 per procedure and 5 pounds of waste per procedure in the office, saving the institution $13,000 with a decreased production of 2.8 tons of waste over 2 years. The authors of this study suggested that nationwide, there would be a $2 million savings and a reduction of 506 tons of waste if all 2,000 hand surgery surgeons in the country did just 100 of these procedures a year. Now at Titletown Orthopedics, in the past year, we've done approximately 400 office procedures, which would suggest that we've decreased supply costs by $4,256 and reduced waste production by over 2,000 pounds. So we need to continue trying to reduce the amount of waste and disposables we consume per procedure in order to continue to help save costs. Now, does the patient actually care where their surgery is performed? And the answer to this question is definitely yes. We have had extremely strong feedback that patients want to factor cost of care into their medical choices. And we have a very high percent of our patients with procedures that can be performed safely in the office, choosing the office over any other site. So 11% of patients have experienced hardships from undergoing surgical care, and 12% had to avoid treating other medical patients or other medical problems because of the cost for some other surgery that they're already paying for. And so it's important to factor in cost of care. And so the patient's opinion on what the doctor's role is, that 60% of patients either agree or strongly agree that a doctor should explain the cost of surgical treatment, and 59% of patients agree that physicians should consider the amount of money a patient will pay when they choose a new treatment. And it has also been shown, the corollary is that physician decisions, independent of what a patient wants, often contribute to up to 80% of healthcare expense. So can these principles of trying to perform safe office-based surgery at a lower cost apply to different healthcare models? So can this be replicated in a federal government facility in the military? So a study was performed looking at a critical analysis of the first 100 procedures and what the patient experience is, as well as cost savings. So a similar wide awake local anesthesia protocol was utilized. They looked at common cases that can be safely performed in the office, such as carpal tunnel release, de Quervain's tendonitis release, trigger finger surgery, hardware removal, etc. And what they found for carpal tunnel release specifically was they saved over $6,000 per case, which was an 85% reduction in cost per carpal tunnel surgery. Over 21 months, the carpal tunnel surgeries performed in the office saved more than $213,000. Patient satisfaction was extremely high, with 94% of those patients preferring wide awake local anesthesia without a tourniquet. When asked to compare their experience with doing hand surgery in the office versus dental procedure in the office, the patients said 72% of the time they felt less pain than going to a dentist. They also had very low anxiety, both pre-surgery, during surgery, and it dropped even lower after surgery. So once they were aware of what was involved, they had very little concerns about proceeding with care in the office. Similar study with respect to safety, as I mentioned previously, very low infection rate, no significant medical problems requiring additional hospital care, monitoring, or admissions to the hospital. So let's look specifically now, rather than the literature, at our own results. So when we analyzed our first 208 procedures that were performed, we found that after the patients were asked about whether they would prefer to have undergone this same procedure in the operating room instead, no patients would have wanted to change their site of service location. And out of the 208 patients, 37 of them selected to go through another office procedure for a different problem, indicating their comfort with this technique. All felt it was the same or easier than going to the dentist, and we had only one infection in 208 procedures, which results in a 0.48% infection risk, which is extremely similar to the literature and expectation for any hospital-based procedures as well. We had no use of need for the phentolamine. We had no presentations to the ER or urgent care. We estimate, in addition to saving money, that the procedure room also saves time. We estimate patients spend approximately an hour to hour and 15 minutes in the building on the day of their procedure, as compared to typically up to 4 hours at the hospital. When we look at the number of minutes saved, it's been over 34,000 total minutes, and which equates to over 570 hours. When we look at the cost of care, if we make an assumption that an office-based surgery costs around $2,000 and a hospital-based procedure costs around $10,000, that would be an 80% difference in cost. When we multiply that times 208 cases, saving $8,000 per case, that would suggest that the procedure room has saved $1.66 million in healthcare expenses. So this is very consistent with what the literature has shown. So we are very proud at Bellin, Titletown Sports Medicine and Orthopedics to deliver a very bright future to our patients, employers, and insurers, where we are carefully looking at ways that we can provide a really highly satisfied, very positive patient experience, but doing so by lowering costs when possible to deliver that high quality care. Thank you very much for looking at this talk that we've done for you today, and we look forward to working with you in the future.